When I'm lonely in the dark, I know you are with me, yeah. Don't you see?
Hello, good morning.
When I'm lonely in the dark, I know you are with me, yeah. Don't you see that I need you so much? Don't you see that I love you so much? Oh na 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 na, oh na 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 na, darling, I need your love. Oh na 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 na, oh na 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 na, darling, I need your love. When I'm lonely in the dark, I know you are with me, yeah. Don't you see that I need you so much? Don't you see that I love you so much? Oh na 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 na, oh na 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 na, darling, I need your love. Oh na 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 na, oh na 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 na, darling, I need. How did I get here? when I'm lonely in the dark. I know you are with me, yeah. Don't you see that I need you so much? Don't you see that I love you so much? Oh na 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 na, oh na 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 na, darling, I need your love. Oh na 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 na, oh na 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 na, darling, I need your love.
Hello. Hello, anything there? There. There is something there. Hello. 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 Ini emang kayak. Hello. 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 Hello, main. Mungkin box sa kanang Hello. Hello, Mike. Hello. 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 Hello, Mike. Hello. Off the mic. Off na. Hello. Hello, Mike. Wala na feedback. Hello. What na?
While advances in the health technologies keep progressing, more complex and the not usually thought of anomalies become more recognized. Presenting to you a rare case.
When I'm lonely in the dark, I know you are with me. Yeah. Don't you see that I need you so much? Don't you see that I love you so much? Oh na 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 na, oh na 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 na, darling, I need your love. Oh na 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 na, oh na 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 na, darling, I need your love. When I'm lonely in the dark, I know you are with me. Yeah. Don't you see that I need you so much? Don't you see that I love you so much? Oh na 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 na, oh na 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 na, darling, I need your love. Oh na 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 na, oh na 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 na, darling, I need your love. like this. Something's always amiss. Can't put my finger on it, but it's there. Wait for it to subside, but my mind won't apply. Waiting for the clear. Is it bad? Sometimes I like it when I lose control. There's something in it that's so beautiful. And I can see the light, but I can also see the bones decay. I don't know what else there is to say. I'm doing my best not to run away. Sitting throwing rocks across the pavement, hoping it'll cave in and swallow me whole. Wondering how the world keeps on spinning, kinda scared of living when it unfolds. Hard to see the light when everything is silent, waiting for the clear. Thankful I'm alive, but terrified of dying. But hey, I'm still here. Is it bad? Sometimes I like it when I lose control. There's something in it that's so beautiful. Listen, I can see the light, but I can also see the bones decay. I don't know what else there is to say. I'm doing my best not to run away. You're the night sky trying to make me see your stars, but the dark gets so lonely. Now I see violet, I can feel silence, and the dark's all that I see. When your stars are burnt out and your heart makes no sound, I'll find violet in your eyes. You'll always be my night sky. You'll always be my night sky. Be my night sky. You'll always be my night sky. You're the night sky hiding behind dark gray clouds. I can't figure you out now. I see your blue. There is so much cold in you, and the silence is so loud when you go. I just stay dancing with my shadow all day. Watch the time. I can't find the point where our two paths align. Right? You're the night sky. I'm trying to see your stars, but I always fear the dark. Now I see violet. I can feel your silence. You always feel so far when your stars are burnt out your heart makes no sound, I'll find valid in your eyes. You'll always be my night sky.
And when I start to think, oh, the tunnel closest starts to end up on the brink. I tried so hard, but all these scars, they cut so deep I bleed. I fell so fast from heaven, it's like someone clipped my wings. Now I'm falling, and I can't see the ground. Can we stop this gravity? It keeps bringing me down. I can't breathe and I don't wanna die. Can we stop this gravity? 'Cause I don't wanna say goodbye. I laid awake just begging to let go. I almost got to suicidal thoughts, but you stepped in. An angel sent from heaven showed me how to live again. Now I'm falling, and I can't see the ground. Can we stop this gravity? It keeps bringing me down. I can't breathe and I don't wanna die. Can we stop this gravity? 'Cause I don't wanna say goodbye.
Baby, wait, I know that you're afraid, but it'll be okay if you just stay with me. And we can run from here, and we can disappear, and they won't find us where we are going, dear. So baby, hold on to me, 'cause I know I can make you believe something that only we can see. Oh, so baby, hold on to me, hold on to me. When it hurts like this, we climb the greatest heights, jump down and have a fight, and that's all we'll ever like. But that can never change my mind. When it's good, it's amazing. When it's bad, it's uneasy. I wouldn't have it another way. There's no other way. When it hurts like this, ever like, ever like, ever like, ever like, ever like, ever like. When it hurts like this, ever like, ever like, ever like, ever like, ever like. When it hurts like this, we hold each other high, but we fall 1,000 times. But I'd never say goodbye or ever leave this stuff behind. When it's good, it's amazing.
Good morning, ladies and gentlemen. The 13th Interdepartmental Interesting Case Presentation Contest is about to start. I would like to request everyone to please direct your attention to the screen for the invocation to be followed by the Philippine National Anthem.
When I'm lonely in the dark, I know you are with me. Yeah. Don't you see that I need you so much? Don't you see that I love you so much? Oh na 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 na, oh na 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 na, darling, I need your love. Oh na 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 na, oh na 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 na, darling, I need your love. When I'm lonely in the dark, I know you are with me. Yeah. Don't you see that I need you so much? Don't you see that I love you so much? Oh na 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 na, oh na 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 na, darling, I need your love. Oh na 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 na, oh na 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 na, darling, I need your love.
Check mic test. Check. Check. Check mic. Check. 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 Check mic test. Check. 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 Check mic test. Check. Check. Check mic test. Check. 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 Check mic test. Check. 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 check, 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 mic. Check, check, mic, check, check. Check, 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 check. Check, check, mic, check, check. check, mic. Check, check, check.
to our Chief Executive Officer, Bishop Jaime Moriles, to our Medical Director, Dr. Michael Hamiana, to our Chief of Clinics, Dr. Mina Angelica Bernardino, to our Graduate Medical Education Office Director, Dr. Larissa Padican, to our panel of judges, Dr. Florence Prantilla, Dr. Melissa C., and Dr. Dova Sayon Gonzalez, to our dear consultants and contestants, ladies and gentlemen, a pleasant morning to all. The late Dr. William James Mayo, a renowned physician and surgeon, once said, "The glory of medicine is that it is constantly moving forward, that there is always more to learn. The ills of today do not cloud the horizon of tomorrow, but act as a spur to greater effort." Even in the midst of this horrible pandemic, in which all are adjusting and eventually living in this so-called new normal, all of us doctors still have the opportunity to learn new things, spanning from the disease entity, the pathophysiology, and management. Indeed, as Bernadette Smith from her podcast, The Power in Purpose, said, and I quote, "We will get through this by seeing every challenge as an opportunity to better serve others. It starts with accepting that the world is bigger than what's in front of us." Ladies and gentlemen, I welcome you to the 13th Interdepartmental Interesting Case Presentation Contest. I am Dr. Lowell Batoon, your MC for today's event. To formally start the program, I would like to call on Dr. Mina Angelica Bernardino, our Chief of Clinics, for the opening remarks.
Good morning, this is Dr. Mina Angelica N. Bernardino from the Radiology Department of Brockenshaire Hospital. To our Chief Executive Officer, Bishop Jaime Moriles, to our Medical Director, Dr. Michael Hamiana, and to our GMETO Director, Dr. Larissa Padican, good morning. With us are carefully chosen judges, namely Dr. Florence P. Prantilla, who is also the Chair of the Board of Judges, and we have Dr. Dova Sayon Gonzalez and Dr. Melissa T.C. To the department chairpersons and training officers who are listening, and to the Brockenshaire medical staff, good morning. To the residents, interns, and clerk, welcome to the 13th Interdepartmental Interesting Case Report Contest. Out of the 22 written entries, only 10 have successfully advanced to presenting their cases orally. I believe these 10 beautiful minds have carefully prepared their reports for us today. To make this opening remark, I was tasked by our dashing and dynamic medical director, Dr. Mike, who is drastically coping with this worldwide drama caused by SARS-CoV-2. But life is a theater, and life must go on, and learning must continue. I hope these interesting cases will be uploaded in your computers up here, so when the time comes that you see the same or similar cases, it can be downloaded successfully. And if you see them, they will not look like new viruses. So without much further ado, let the presentation of cases begin.
Thank you very much, Dr. Bernardino. At this juncture, I would like to call on the GMETO Hospital Chief Resident, Dr. Haris Rashid, to introduce our distinguished panel of judges and also to dictate the mechanics of the contest.
Thank you, Dr. Batoon. So, good morning once again, ladies and gentlemen.
Doctors, presenters, and Haris Rashid, GMETO Chief Resident, warmly welcoming you and honored to introduce the judges for today's 13th Interdepartmental Interesting Case Presentation Contest of the year 2020.
Our first
judge, graduate of cum laude
Medical Technology, studied Doctor of Medicine in Jose P. Rizal School of Medicine, Xavier University of the year 2005-2009. She was chosen as the best intern of our institution last 2009-2010. Our judge finished her residency training in St. Luke's Medical Center Institute of Pediatric and Child Health and became a chief fellow of the said institution of the clinical nutrition last 2011-2017. Our doctor is a member of American Society of Parenteral and Enteral Nutrition, a diplomate of Philippine Pediatric Society, and Philippine Board of Clinical Nutrition. Currently, she is an active pediatric consultant and a clinical nutrition physician of the Metro Davao and Medical Research Center, Incorporated, Southern Philippines Medical Center, and San Pedro Hospital. She is also a lecturer of nutrition for Pediatric Department in Brokenshire College, School of Medicine, and Davao Medical School Foundation. Everyone, please help me welcome our first judge, Dr. Melissa Chopicosi. Our next judge, a graduate of BS Physical Therapy in the year 2002, and finished her Doctor of Medicine in the year 2007 from the Davao Medical School Foundation, Incorporated. She was awarded as the Most Outstanding Intern and Academic Excellence Awardee in the Southern Philippines Medical Center in the year 2008. In 2011, she finished her training in the Journal of Psychiatry in the Institute of Psychiatry and Behavioral Medicine, SPMC, and completed Psychosomatic Medicine in 2014 at the Medical City Ortigas. She earned third place in the Psychiatric Diplomate Board exam. She conferred her fellowship of the Philippine Psychiatric Association last 2018. She also published 2 research papers entitled, first, a study on the practice in the management of delirium among admitted adult patients in the medical city. Second, prevalence of psychopathy among institutionalized adolescent offenders in Davao City. She was the past training officer in the Institute of Psychiatry and Behavioral Medicine and currently affiliated to Davao City's leading hospitals. Ladies and gentlemen, our second judge, Dr. Dova Onsayan Gonzalez. For our last judge, Chairman of Judges, a BS Biology graduate of University of the Philippines, Los Baños, 1990, and finished her Doctor of Medicine 1995 in the De La Salle College of Medicine, Dasmariñas, Cavite. She had her anesthesiology residency training in the Davao Medical Center, currently known as the Southern Philippines Medical Center, in the year 1996 to 1998. She is also a registered nurse in New Jersey, USA in the year 2007, and a progressive care certified nurse for adult patients in US from 2011. It's my joy and honor to welcome Dr. Florence Brantilla. So for the mechanics of the contest, oral component. Each presentation must not exceed 8 minutes. The moderator will tell the presenter to start the presentation. A green bulb will be switched on and time count will start the moment the presenter starts talking. On the 6th minute, a yellow bulb will be switched on by the timekeeper. And the 8th minute, a red bulb will be switched on by the timekeeper and the moderator will advise the presenter to end the presentation. The presenter can no longer proceed the presentation after the moderator's advice to stop. Each of the judges will be allowed to give comments and ask questions from the presenter. The moderator will facilitate the flow of this portion of the presentation to contain all questions and answers within 3 minutes. Oral presentations will be judged using the following criteria. Adherence to time limit, 5 points. Presentation skills, 10 points. Mastery of the case, 15 points. Audio-visual aids, 10 points, for a total of 40 points. After giving scores to all presenters, each judge will rank the entries. Ranks of the 3 judges will be summed up per entry in order to come up with the overall ranking. The entry with the least sum will have the highest rank. The judges will declare our 4 winners with the following corresponding prizes. First place, 3,000 and certificates of recognition for the participant plus a medal. Second place, 2,000 and certificate of recognition for the participant plus a medal. Third place, 1,000 and certificate of recognition for the participant and a medal. And special awards for a best presenter, a special prize of 1,000 and a certificate of recognition plus a medal, and a Voter's Choice Award which will have a certificate of recognition. A revolving trophy kept by the Department of
This grant champion will be passed on to the next grant champion.
consecutive years, they will keep the revolving trophy forever. And lastly, the decision of the judges will be final. Thank you.
Thank you very much, Dr. Rashid. Before we start, is unique in that the winner is not chosen by one of the judges, but by the audience themselves. We'll be awarding the voter's choice at the end of the presentation, so there is a link posted in the comment section of your YouTube live feed. Please click on the link and vote for your favorite interesting research partner. Voter's choice award will go to the presenter who will have the highest number of votes. So just a few reminders for our contestants. The contestants will remove their masks and face shields once they are allowed on stage and on the podium during the oral presentation. They are required to put their masks back on before going on stage. Before the contest starts, here is a rundown of the interesting case reports to be presented in the following order. So the first presenter will present a case of a 40-year-old mother with a sad fetal syndrome, ethical and management dilemma, followed by a case of Laryngomalacia in a newborn, followed by a case of a 14-year-old male with cervical spine juvenile melanoma, followed by a case of a 25-year-old female with soft twisting nephropathy, followed by early Uterine syndrome with a 30-year-old girl, followed by a spontaneous common carotid artery dissection with a 41-year-old male with stroke, followed by Ameloblastoma carcinoma, a rare Ameloblastoma malignancy with a 70-year-old female, followed by a rare case of Hirschsprung disease and intestinal malformation on an 18-day female, followed by a case of Hemolytic uremic syndrome with a 30-year-old breastfed infant, and last but not the least, a case of a 31-year-old male with Cushing syndrome induced by cowhead males, a Chinese neural medicine. So to our contestants, how are you feeling today? Are you all nervous, excited? Motions, please.
Well, I've been in your position before and I got to see it was the longest 11 minutes of my life. But once you were able to present and defend your cases, it will be all worth it in the end. Well, are you all ready to showcase your interesting case reports? Because we will start the ball rolling. So to all the contestants, good luck to all of you. The first contestant may come up on stage and start with the presentation.
When I'm lonely in the dark, I know you are with me, yeah. Don't you see that I need you so much? Don't you see that I love you so much? Oh na 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 na, oh na 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 na, darling, I need your love. Oh na 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 na, oh na 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 na, darling, I need your love.
Hello. Hello, mic test. Test mic. Mic test. Mic test. Mic test. Twins produces twice the joy, twice the love, and twice the blessings. However, a fog of uncertainty conceals our future up until the end, the sad fetus syndrome. This is the case of a 40-year-old gravida 4 para 2, at 29 weeks age of gestation, who presented with labor pains and profuse vaginal bleeding. Her story started at 16th week gestation when she sought consult after an episode of vaginal spotting. Ultrasound revealed a live fetus with a normal placenta and a possible twin partial hydatidiform mole. At 18 weeks, the beta HCG level was extremely high and the other ancillary tests were all abnormal. She was diagnosed with preeclampsia with HELP syndrome, threatened abortion, twin molar with a coexisting live fetus, and hyperthyroidism. Maintenance medications were given and a strict weekly prenatal checkup was advised. At 20 weeks, a fetal anomaly scan revealed intrauterine twin gestation with molar pregnancy and a coexisting live fetus with no gross structural abnormalities. The placenta was located anterior, high-lying with posterior echogenic structure with hypoechoic foci. At 29 weeks, she was then admitted due to uterine contractions with profuse vaginal bleeding. Her past medical, family, and personal social history were both unremarkable. Obstetrical and gynecological history were the following, as well as the obstetrical score. Pertinent PE revealed BP of 150/90, fundic height of 30 cm, with episodes of headaches and palpitations. She eventually delivered a live baby girl, followed by a grossly normal placenta. Postpartum hemorrhage was noted, hence the planned total abdominal hysterectomy with mole in situ was performed. Intraoperatively, a 10 by 10 cm molar mass was implanted at the anterofundal area with areas of poor demarcation between molar tissue and decidua. The beta HCG significantly dropped. She had a total of 4 units of blood and discharged on the 3rd post-op day. The baby was discharged well 3 months post-delivery. The final histopathologic result revealed partial hydatidiform mole with an indeterminate result of P57 immunohistochemistry staining that warrants further study. Thus, the final diagnosis is: the patient had an intrauterine twin gestation of partial hydatidiform mole and a coexisting live fetus, and was later confirmed intrapartum a spontaneous delivery of a grossly normal placenta and a molar mass in utero. With the above salient features, placental mesenchymal dysplasia and chorioangioma were initially considered, but were eventually ruled out. PMD is a rare vascular anomaly seen in the placenta. The affected placenta appears massive than normal and the beta HCG level is normal, but not seen in this case. Chorioangioma shows increased vascularity or a large feeding vessel inside the tumor, with the same pulsation as in the umbilical cord. This was not seen in the repeated scans in this case. Thus, twin pregnancy of a partial mole with a live fetus and normal placenta was considered, as confirmed by histopathology. Hydatidiform mole is mainly caused by abnormal fertilization of ovum and sperm, resulting to abnormal growth of trophoblasts. The two main types are complete and partial mole based on gross morphology, histopathology, and fetal karyotype. The fetal karyotype in partial mole will show a faulty chromosomal outcome of either triploidy or heteroploidy. Most of the fetus typically do not survive beyond the first trimester, due to fetal anomaly of triploidy. However, in heteroploidy, this is when a rare phenomenon of a twin molar gestation with a live fetus can be produced. This twinning of a partial mole with a coexistent viable fetus is a very rare subclass of twin molar gestation, with an incidence rate of 0.005% to 0.01% of all pregnancies. It is a very sad situation because it is associated with poor pregnancy outcomes such as the following. Hence the term sad fetus syndrome. Going back to the patient, she had an atypical presentation of a partial mole with coexisting live fetus as it had markedly elevated beta-HCG levels that developed early complications of severe preeclampsia, HELP syndrome, and hyperthyroidism that accounts 5% of all cases. She made aware of the maternal and fetal consequences, but they opted to continue the pregnancy with intensive monitoring. As shown in this case, diagnosing a molar pregnancy having coexisting fetus is complex. It can be achieved through ultrasonography and delicate measurement of serum beta-HCG, typically in the first trimester. Moreover, important prognostic factors for fetal survival will depend on the following: fetus's standard karyotype, the size of the molar placenta, maternal age, and the coexisting maternal complications. Typically, a post-delivery serial beta-HCG monitoring and a close follow-up should be done. Chemoprophylaxis is given to patients with high risk of developing gestational trophoblastic neoplasia. She was advised methotrexate therapy but was not instituted due to post-op sepsis. 10 weeks post-delivery, beta-HCG is decreasing. The infant currently weighs 6 kilograms and is thriving well. A partial mole with a coexisting live newborn who survives is an extremely rare case. Only 10 published cases were found worldwide. This case report emphasizes the lack of clinical practice guidelines, early diagnosis, management, recognition of complications, and counseling of a patient having twin partial mole with a coexistent live fetus would result in a successful pregnancy. From the outside looking in, it is hard to understand a mother's sacrifice. From the inside looking out, it is complicated to explain mother's love to an unborn child. Good morning.
Thank you, doctor, for sharing with us your very interesting case. Your case presented a lot of dilemmas aside from the fate of the pregnancy. Now my question is, as an OBGYN resident in training, what is your personal ethical dilemma as the stakeholder that provides medical service, and how did you approach to resolve this in your case?
Good. Good morning again, Dr. Sayon. Can you please repeat the question po?
Okay. My question here, as an OBGYN resident in training, what is your personal ethical dilemma as the stakeholder that provides the medical service, and how did you approach to resolve this in your case?
Thank you for the question. Thank you for the question, doctor. Regarding the ethical dilemma and the management of this case, since the patient is having partial mole, there is a possible instance that the fetus is having chromosomal abnormalities. So during the second trimester, we should have done chromosomal or karyotyping for the patient. However, due to some financial problems with the parents, thus fetal karyotyping was not done. So it was actually a dilemma in our part because in the Philippines, there is still no clinical practice guidelines regarding this. We were following the clinical practice guidelines from other countries wherein termination of pregnancy is legal. But here in the Philippines, it is not legal. So it is really an ethical dilemma regarding our case.
Okay, thank you.
For the other panel of judges, do you have any additional questions for our first presenter?
Hi, good morning. I'd like to ask a question. Hi, good morning.
So thank you for the question. Given the chance to redo the management, the proper management with this case is close monitoring with bi-monthly beta HCG monitoring prior to delivery, so that we would know the time wherein the expected fetal delivery would happen. So with this case, there was no bi-monthly beta ECG monitoring since the patient is financially incapable. So it is better that the doctor or someone who is financially capable could help this patient, since this is really a good case to manage.
So for Dr. Melissa C, no more additional questions. So thank you so much, Dr. Quintanar, for your presentation. Let's proceed to our second presenter.
Poetry is music to the ears as the first cry of a newborn baby to its mother. But nothing is what it seems to be. What we see is only a fractional part of an immense reality. This is a case of baby EO, born to a 33-year-old primi-gravid via normal spontaneous vaginal delivery, term with a birth weight of 3 kilograms and UPGAR score of 7.9. The pregnancy was unremarkable and normal prenatal ultrasounds. There were no heredofamilial diseases or complications during delivery. At birth, EO had good cry, tone, and activity, with vital signs and anthropometric measurements, all appropriate for age. The general physical examination was unremarkable. She was managed as a well baby until the 5th hour of life, when she was observed to have noisy breathing and frequent feeding interruptions. Upon examination, she had tachypnea and inspiratory stridor associated with alar flaring, mild subcostal retractions, and fine crackles at the right lung field. No murmur was appreciated. Oxygen saturation on all extremities showed hypoxemia of 91% at room air. Thus, oxygen support and hyperextension of the neck was provided, which showed clinical improvement. At this point, sepsis and pneumonia were considered. Hence, septic workup was done. CBC showed thrombocytopenia, ABG showed partially compensated metabolic acidosis, and chest X-ray revealed pneumonia. Systemic antibiotics were then started with a note of resolution after 7 days. But still, the baby cannot tolerate room air, and attempts to breastfeed cause respiratory distress, giving us now an enigma of what might possibly cause such presentation. Perhaps, the stridor would lead us to more possibilities. Age of onset is an important determinant that can help identify the cause of stridor. In neonates, congenital disorders generally present in the first few weeks of life. The timing of stridor can be used to identify the likely region of airway affected. Our patient presented with inspiratory stridor, thus expiratory stridor were unlikely thought of. Vocal cord paralysis is considered due to its inspiratory stridor component. However, it is less likely considered due to the absence of cardiac surgery and history of traumatic delivery. Laryngeal webs is also considered. Both conditions need flexible fiber optic laryngoscopy to rule it out. Inspiratory stridor suggests supraglottic pathologies. It is present in congenital laryngeal saccular cyst and laryngomalacia, with presentation the same as baby EOs, but still require a fiber optic laryngoscopy for definitive diagnosis. Baby EO was referred to a pediatric pulmonologist who suggested for a direct visualization of the upper airway. Unfortunately, an age-appropriate size scope is not available locally. Hence, she was referred to a pediatric ENT and proceeded with the diagnostic and definitive treatment performed in a government tertiary hospital in Davao. She underwent flexible laryngoscopy, which revealed floppy epiglottis, covering and obstructing the glottic opening. The larynx had laryngomalacia features causing airway obstruction. Laryngotracheal bronchoscopy showed the same findings. The laryngoscopic finding has brought to light what caused baby EO's persistent stridor and respiratory distress. The before-mentioned differential diagnoses were finally ruled out and concluded with the diagnosis of congenital laryngomalacia severe. She was then subjected to supraglottoplasty with epiglottopex. The patient was extubated 4 days post-op and observed with no recurrence of stridor, retractions, and desaturations. Unfortunately, on the 15th post-op day, EO developed healthcare-associated pneumonia, thus an emergency tracheostomy was performed due to airway compromise. After a month of hospital stay, EO was discharged, improved. Congenital stridor is one of the rare presentations of respiratory distress at birth, and laryngomalacia is the most common congenital laryngeal anomaly leading to inward collapse of the supraglottic airway with inspiration. Worldwide, the incidence is estimated to be 1 in 2,000 to 3,000, with symptoms of noisy breathing appearing as early as the patient presented earlier on the 5th hour of life. Among the earliest case reported was a 2-hour-old male infant in India who had excessive drooling of saliva and respiratory distress. Laryngoscopy revealed moderate laryngomalacia. However, this was associated with another rare disorder. According to the PPS, in 14 years, there were only 69 reported cases of infants less than 28 days old, and out of 69 cases, only 2 came from Mindanao, particularly in Davao City, making this the third reported case and maybe the youngest in Davao. There are several theories about the pathophysiology of laryngomalacia. The severity of laryngomalacia was determined based on the presenting symptoms and physical examination. 20% of infants with severe type have stridor associated with average resting baseline oxygen saturation of 86% and feeding difficulties which baby EO presented. Presumptive diagnosis can be made clinically, but the definitive diagnosis can only be made during laryngoscopy. Management can be stratified according to the disease severity. Those patients with worsening symptoms like our case, despite feeding modification, require further investigation and surgical intervention in addition to acid suppression treatment. Surgically, the current standard treatment is supraglottopex and epiglottopex with a success rate of approximately 94%. Surgical revision is influenced by failure of clinical improvement and comorbidities such as GERD and synchronous airway lesions. Standard follow-up is usually performed 6 weeks after initial endoscopy. A second diagnostic endoscopy will be performed as early as 1 year if there is no sufficient improvement. This has been EO's daily struggles, fighting for a life she barely started. Firm, unyielding, and with unforeseen resilience she endured at a young age. Baby EO and family may have wrestled against life, but their hope carried them through the test of time. The life of EO has been a journey from sickness to success. Thank you and good morning.
Good morning, Dr. Delaguan. Thank you for presenting a case in which the timely intervention really leads to the success of this case. Now, my question is that in your case, you have a first-time mother whose infant undergoes multiple procedures and intubation. The mother is obviously postpartum, and how did you facilitate communication with the parents, especially the mother, to foster partnership in EO's care?
Hello? During birth, EO had presented stridor on the 5th hour of life. Since then, appraisal to the parents has been made regarding the patient's condition, and the management has been provided. So the family, particularly the mother, knows what the procedures and the management are to be done to the patient. With regards to the surgical intervention, there was a family conference made with the pulmonologist, the main attending physician, the pediatric ENT regarding the possible complications or the run-through of the procedure. And the mother, or the family rather, was at ease with this explanation. So with the parents or the family are contented with what happened to this patient since it is a successful operation.
Thank you.
Okay. Okay. Okay, so thank you, Dr. Dalaguan. So for Dr. Prantilia's question, what is the long-term plan for managing the tracheostomy tube? When will it be removed?
Currently, the tracheostomy tube hasn't been removed as of the moment, since the patient is still ongoing follow-up checkup. And also, due to this pandemic, there was no decision to divulge when will the tracheostomy be removed. The factors that might influence the persistence of the tracheostomy might be the feeding difficulties, the symptom of airway compromise of the patient. So the consultant and the medical team will look or follow up the patient, how she progressed as a discharged patient with this tracheostomy.
Okay, so for the last question from Dr. Melissa C., what is the importance of multidisciplinary management of your case? And as a pediatrician of the patient, what is the future plans for the patient?
In this case, multidisciplinary management has been appreciated since, firstly, as a clinician, we must not only focus or put into a box the symptoms of a patient, but as well admit to ourselves that there might be conditions that cannot be seen outside and needs further evaluation. That is why the patient was also referred to another department.
Okay, thank you so much, Dr. Dalaguan, for your presentation. So let us proceed with the third presenter.
Difficult roads often lead to beautiful destinations. Storming through these roads, unequipped and debilitated, may challenge one's spirit to continue the journey. The question is, will your faith overpower your fear? This is a case of KB, a 14-year-old male from Turil, Davao City, admitted with a chief complaint of body weakness and difficulty of breathing. He was apparently well until 2 months prior to admission when he started to experience tolerable knee pain with no other associated symptoms. 3 weeks prior to admission, the knee pain persisted, now associated with numbness and tingling sensation of the right upper extremity. The patient sought consultation at a local hospital where a brain pathology was considered. Luckily, cranial CT scan revealed normal. 2 weeks prior to admission, the numbness progressed to involve both lower extremities, now associated with weakness, body malaise, easy fatigability, dysphagia, occasional shortness of breath, and bladder and bowel incontinence. On the day of admission, he had marked difficulty of breathing, prompting consultation and subsequent admission. Prenatal and natal history was unremarkable. Patient is on diet for age. He was completely immunized at a local health center. Past medical history was unremarkable. Hereditary familial diseases noted were hypertension and diabetes mellitus in the maternal side. Upon physical examination, KB was examined conscious, coherent, and in respiratory distress with the following vital signs. Pertinent PE findings were airway flaring, harsh breath sounds, with subcostal and intercostal retractions, with distended hypogastric area and lax expanteric tone. Pertinent neuroexamination revealed slight difficulty in doing shoulder shrug. Motor function tests revealed beginning atrophy and flaccid muscle tone in all extremities. Motor strength were 0/5 on the upper extremities and 1 to 2/5 on the lower extremities. With sensory deficit as follows. Deep tendon reflexes were normal. A positive bilateral Babinski were noted, and meningeal signs were absent. With the history and neurologic examination findings, our impression upon admission was acute flaccid paralysis. Upon admission, workup was done, which revealed right upper lobe pneumonia with leukocytosis of 17.8 and a positive CRP with compensated respiratory acidosis on ABG. Patient was then intubated and hooked to mechanical ventilator. Referrals to pediatric intensivist and neurosurgeon was done. He was also started with the following medications. MRI of the cervical spine was done, revealing an ovoid mass with well-defined margins in the intradural extramedullary regions at C2, C4 levels at the right side of spinal canal. On the third hospital day, KB was then scheduled for C2, C4 light hemilaminectomy. Intraoperative findings revealed white tissue aggregates measuring 4 cms. Specimen was then sent for biopsy. KB improved and was extubated and strand out to ward. He was put on rehabilitation and physical therapy. With gradual improvement in his sensory and motor strength, he also regained his bowel and bladder control. And on the 15th hospital day, KB was discharged improved. According to the Philippine Acute Flaccid Paralysis Program, AFP is a syndrome manifested as floppy paralysis. An AFP case is a child under 15 years of age with acute onset of floppy paralysis. Given the salient features, the following diseases were considered. Disorders of the neuromuscular junction, a CNS etiology, an anterior horn disease, disease in the peripheral nerves, or by space-occupying lesion. In this case, a space-occupying lesion was highly entertained. Initial biopsy revealed medulloblastoma. However, clinical description and manifestation of medulloblastoma was not compatible with our patient. Further investigation was done and review of slide with immunohistochemistry was performed at a higher medical facility. Microscopy showed histocytic proliferation with xanthoma cells and Teuton-type giant cells. Immunohistochemistry result revealed a positive CD68 compatible with histiocytes consistent with juvenile xanthogranuloma. Juvenile xanthogranuloma is a rare non-Langerhans cells histiocytosis that is usually benign and self-limiting. The cause of disease is unknown. It occurs most often in the skin of the head, neck, and trunk. Most common extracutaneous lesion is in the eye. KB does not have any skin and eye manifestations. JXG affects infants and small children with an average age of 2 years, commonly affecting males. Our patient is a 14-year-old male, making this case a rare one. In literatures, the last recorded case of spinal JXG was in 2018. A case of a 1-year-old girl initially noted with reduced activity of lower limbs. Histology showed Teuton-type giant cells with positive CD68. Solitary JXG, especially involving the spine, is very rare. Only 14 cases has been described in the English literature. 9 cases were under pediatric age group, 4 cases seen in the cervical spine, maybe making our case the 10th pediatric case and the 5th cervical spine case. Xanthogranuloma is confirmed through histopathologic and immunohistochemical studies. Microscopically, there are foamy histiocyte cells with or without total giant cells. These are all seen in our patient. A spontaneous regression of the skin lesion is a natural course. Currently, no standard treatments for solitary xanthogranuloma involving the CNS because of extremely low incidence. Complete surgical resection of tumor is curative. Just like KB's case, after several sessions of physical therapy, KB is now able to ambulate, walk unassisted, and do activities of daily living. The journey of KB in recovering and getting back to his normal state is not just one-man effort, but by God's grace, patient's cooperation, his family, and the extra mile of service and commitment by the different health practitioners made this story a success, making his first independent walk a walk to remember. Thank you and good morning.
So thank you very much, Dr. Bellarmino, for your presentation. So from Dr. Sayon, her question is, what can you do to facilitate cooperation and sense of responsibility to your teen patient whose management requires constant monitoring and has a history of non-compliance to previous medical recommendations?
In order to secure, in order to maintain a good follow-up or management or for the patient, we also include the family of the patient in understanding on how the disease, on all about the disease. So we not only the patient but also the parents will be involved in the treatment plan. Also, as a teenager, you should talk to the patient and let him understand the importance of a good follow-up, and also encourage the patient to do not lose hope, because nothing is impossible as long as you follow the treatment plan or the plan of the service.
Okay, so from Dr. Prantilla, her question is, what is the long-term prognosis for this patient? Is there a chance the disease will recur in adulthood?
Actually, Doc, the disease is a benign one. So, according to the literature, there is a very small chance of recurrence.
Okay, so thank you. So, for Dr. Melissa C., do you have any questions? So for Dr. Melissa C., multidisciplinary management is important as what you said. What composes your team and where do you refer?
The team who managed that patient was composed of a neurosurgeon, an intensivist, and a pediatric neurologist.
Okay, so thank you very much, Dr. Bellarmino, for your presentation. So let's proceed with our fourth presenter. So as you can notice, I am the ones who are reading the questions of the judges due to the technical difficulties.
Good morning. Imagine waking up one morning unable to move. You're anxious, confused, horrified. Are you still truly alive? This is the case of a 21-year-old female who came in the emergency room due to generalized body weakness. She had decreased appetite, abdominal cramps, vomiting, semi-solid stool, body weakness, numbness, spasm, and palpitations. Hours prior to admission, she had difficulty standing and walking and temporarily was unable to move the legs. She was already admitted 3 times due to the body weakness. 2 years ago, it was noted that the potassium, magnesium, and calcium were all low and the ultrasound considered renal parenchymal disease. She was discharged with potassium, calcium, and magnesium supplementation. At the ER, she was slightly tachycardic and tachypnic. She was in pain due to the muscular cramps. She had no signs of dehydration. Striking was that she presented with bilateral carpopedal spasm but with negative Vostek sign. Motor strength on the upper extremities were 4/5 and 3/5 on the lower extremities. She was initially managed as a case of multiple electrolyte imbalance secondary to decreased intake and gastrointestinal losses. The serum electrolytes ordered were all low. Plain NSS with potassium chloride and calcium magnesium tablets were started. Serum creatinine was high and the eGFR was low at 29. Her 24-hour urine potassium was 18.80 millimoles. On the 4th day, she had 2 hypotensive episodes at 80/50, which normalized after giving saline boluses. Repeat serum magnesium result was lower than the initial. Cycles of magnesium sulfate drip started. The nephrology service was consulted and gave her spironolactone for potassium retention. The working diagnosis at that time was chronic kidney disease secondary to renal tubular acidosis versus Gittelman syndrome. TSH and FT4 ordered were both within normal limits. On discharge, the potassium was already within normal limits. The sodium and magnesium were also corrected, but the creatinine was still high and the eGFR was still at 51.9. The ultrasound of the whole abdomen result revealed a result similar to 2 years ago. Her condition improved and she was discharged with these maintenance medications. The final diagnosis was chronic kidney disease secondary to chronic hypokalemia, secondary to chronic tubulointerstitial nephritis, cannot rule out Gittelman syndrome. Brenner and Rector introduced an algorithm on the diagnostic approach to hypokalemia. We consider differential diagnosis under inadequate potassium intake, potassium shift, non-renal, and renal loss. First, we considered hypokalemic periodic paralysis. However, this does not explain for the decrease in the other electrolytes, and as an autosomal dominant disease, no other family members had the same symptoms. Multiple electrolyte imbalance due to decreased intake was also considered, but there was no clear evidence of low intake and prolonged hunger. She was still eating and was not skipping meals. Shift of potassium from extracellular to intracellular, which includes thyrotoxic periodic paralysis, was ruled out because she was not using beta-2 adrenergic agonists, insulin, and she had normal TSH and FT4 results. Hypokalemia due to non-renal loss was ruled out because she did not have persistent vomiting, diarrhea, and profuse sweating. In line with the algorithm, 24-hour urine potassium was ordered and the result was 18.80 millimoles, which means there was significant renal loss. The transtubular potassium gradient is calculated to be more than 4, which suggests distal potassium secretion. Next is to note whether she was normal, hypo, or hypertensive. In the ward, her blood pressure ranged from 80/60 to 120/80, so she had low or normal blood pressure. The next step is to determine the acid-base status of the patient. However, since AVG was not taken, we are left with renal tubular acidosis, Barter's, and Gittelman syndrome. In renal tubular acidosis, there is impaired renal hydrogen excretion in type 1 RTA and impaired bicarbonate resorption in type 2 RTA. The patient may not have type 1 RTA because she did not present with complications of nephrocalcinosis and nephrolithiasis. She did not take drugs such as amphotericin B, ifosfamide, and lithium. She was not a kidney transplant patient nor diagnosed with any disorders causing secondary RTA. Type 2 RTA patients can have increased urinary excretion of glucose, protein, potassium, and amino acids. But our patient had no glucosuria nor proteinuria. Her electrolyte derangement also improved even without alkali supplementation, which was needed for correction. Bartter syndrome more commonly presents in infancy and early childhood and may cause growth retardation, failure to thrive, and deafness, which were not experienced by our patient. The patient did not have history of polyhydramnios and prematurity, which could suggest Bartter syndrome, and it is not common for patients with this syndrome to have low serum magnesium. Lastly, we considered Gitelman syndrome. In 1966, Gitelman described 3 adult females with muscle weakness, tetani, hypokalemia, hypomagnesemia, and hypocalciuria. The disorder is called Gitelman syndrome. The prevalence is 1 to 10 in 40,000 and potentially higher in Asia. The population affected are mainly adolescents and adults. Again, the patient is in an adult age group with muscle weakness, spasm, hypokalemia, and hypomagnesemia. In Gitelman syndrome, there is a mutation in the SLC12A3 gene. There is increased sodium and chloride delivery and absorption in the collecting tubule, but there is also an increase in the excretion of potassium and hydrogen. There is also reduced expression of TRPM6 channels in the distal tubule and duodenum, which results in urinary and intestinal magnesium wasting. In the systematic review of cases of Gitelman syndrome done by Shahzad et al., out of 122 patients, 63% are females. The patient presented with weakness, cramps, carpopedal spasm, nausea, vomiting, paralysis, and numbness, which mostly were presented by our patient. The Kidney Disease Improving Global Outcomes made an expert consensus statement on Gitelman syndrome. This inverted pyramid showed the signs and symptoms with their frequency on patients with Gitelman syndrome. A lot of these signs and symptoms were also present in our patient. Gitelman syndrome is definitively diagnosed by genetic testing, but in the study again, more than half of the patients were diagnosed with Gitelman syndrome even without genetic testing. They were diagnosed based on the electrolyte abnormalities and clinical picture. The management is lifelong potassium and magnesium supplementation. Sodium chloride intake should also be strongly advocated. For our patient again, she was prescribed with potassium and magnesium supplementation and a potassium-sparing diuretic. In general, the prognosis is excellent, and there is no evidence that Gitelman syndrome affects life expectancy. A month after the discharge, the family called us because the patient again was experiencing the symptoms. They were not able to steadily provide for the medications. The department gave some supplies, and after a week, we followed them up, and the patient was better. We plan to help them identify resources to help them in getting a steady supply of medications. In this case, I learned that one should accept one's limitations, work harmoniously with others, provide continuity of care, and help patients and families to continue onward and forward in life. Thank you.
Thank you, Dr. Villanes, for your presentation. So let's hear from our judges. Okay. So from Dr. Melissa C., what are your home instructions to the patient and what is your future plans for her?
So our instructions to the patient consist of the medications, mainly of the medications and the diet. First, we thoroughly explain to the patient that she might have a disease that needs to be provided with continuous supply of the electrolyte replenishment. And second was regarding the diet, we told her that she could eat anything that she wants, and we told her about the fruits and food that are rich in potassium, magnesium, and also sodium. So that's it.
Okay, thank you. So no questions from Dr. Prantilla. And for Dr. Sayon, your patient requires a lifelong electrolyte supplementation. What will be your intervention to increase treatment adherence to the patient?
Actually, this patient was enrolled in our family health case program. This includes enrolling the patient and the family into our care. So as residents, we follow up the patient, and the patients can also come to us and for consultation. So about 4 days ago, we called the patient if they were able to adherently follow our instructions and medications. Unfortunately, because of the pandemic today, the father and mother has no jobs. And so again, we are trying to find agencies or centers where they can be supplied with continuous medications. And we also gave them new supplies for the electrolyte replenishment.
Okay, thank you, Dr. Villanes. So thank you very much for your presentation. Okay. So for our fifth contestant, Dr. Serrano will be, Dr. Serrano, her presentation will actually be pre-recorded. However, she will be answering the questions live.
While advances in the health technologies keep progressing, more complex and the not usually thought of anomalies become more recognized. Presenting to you a rare case of Herrlin-Werner-Wunderlich syndrome. A 13-year-old girl presented with dysmenorrhea with a pain scale of 10 out of 10, 5 months after her menarche. Once her menses were over, crampy hypogastric pain with a pain scale of 6 to 7 out of 10 persisted, radiating to the back, associated with whitish non-foul discharge. No consultation was done until 5 days prior to admission due to persistence of symptoms. She's a known asthmatic with unrecalled last attack and without maintenance medications. She's a grade 8 student without sexual activity. Transabdominal ultrasound revealed uterine anomaly. Transrectal and abdominal 3D ultrasound revealed uterine didelphys, double cervix, longitudinal obstructing vaginal septum, left adnexal cyst suggestive of an endometriotic ovarian cyst, and a right adnexal mass suggestive of a benign multilocular ovarian cyst. Left kidney was absent. She was then admitted for surgery. Physical examination revealed stable vital signs. Breast and external genitalia, Tanner stage 2. The abdomen revealed a 7 by 7 centimeters, smooth, hard, movable, non-tender hypogastric mass. With the following salient features: endometriosis, ovarian new growth, and pelvic infection were the initial considerations. Although she had no urinary or bowel symptoms, urinary and gastrointestinal conditions were also considered. In pediatric patients presenting with gynecologic problems, congenital anomalies must also be ruled out. The preoperative diagnoses were Herrlin-Werner-Wunderlich syndrome, bilateral ovarian new growth, probably benign. Ultrasound of KUB revealed absent left kidney. CA125 was elevated. The patient underwent combined laparoscopy and hysteroscopy. On laparoscopy, the uterus had 2 separate corpora. Both ovaries were cystically enlarged. The left ovary was enveloped by the omentum. It was adherent to the left pelvic sidewall and rectosigmoid column. The left ovarian mass was then punctured, draining thick, chocolate-colored fluid with smooth internal wall. Left salpingo-oophorectomy was done. On hysteroscopy, a longitudinal vaginal septum with obstructed hemivagina was noted, filled with old blood. It was punctured and excised. Histopathology report of the left ovary was consistent with endometriosis. The final diagnoses were pelvic endometriosis with left endometrioma stage 3, Herrlin-Werner-Wunderlich syndrome, longitudinal vaginal septum. Obstructed hemivagina with ipsilateral renal anomaly in combination with uterine didelphys is known as Herrlin-Werner-Wunderlich syndrome. Herrlin and Werner in 1971 described this. There is a 0.5 to 6.7% prevalence in the general population. 0.1 to 3.5% is the reported incidence in the Philippines. This Mullerian anomaly is due to the failed fusion of the paired Mullerian ducts around 12 weeks age of gestation, causing the uterine didelphys. At 20 weeks age of gestation, due to failure of the lateral fusion of the paired Mullerian ducts or failure of the resorption of the vaginal septum, presence of a longitudinal vaginal septum occurs. The early failure of the metanephric diverticulum to develop at 5 weeks age of gestation from the mesonephric duct results in a genesis of the ureteric bud, thus a genesis of the left kidney. These are the signs and symptoms. The patient presented with dysmenorrhea and pelvic pain, abdominal mass, and minimal whitish non-foul discharge. The blood buildup on the left hemivagina produced dysmenorrhea and persistent hypogastric pain. There are two types of Hurlin-Werner-Wunderlich syndrome, complete and incomplete. Classification 1 has a completely obstructed hemivagina with or without cervical aplasia, while classification 2 has a small communication between the vaginas or uteri. The patient has classification 1 because the onset of symptoms and diagnosis were 4 months after menarche. Dysmenorrhea, abdominal pain, and endometriosis were present. The progression to secondary endometriosis and adhesions was quick and easy.
When I'm lonely in the dark, I know you are with me, yeah. Don't you see that I need you so much? Don't you see that I love you so much? Oh na 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 na, oh na 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 na, darling, I need your love. Oh na 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 na, oh na 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 na, darling, I need your love. When I'm lonely in the dark, I know you are with me, yeah. Don't you see that I need you so much? Don't you see that I love you so much? Oh na 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 na, oh na 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 na, darling, I need your love. Oh na 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 na, oh na 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 na, darling, I need your love.
advances in the health technologies keep progressing, more complex and the not usually While advances in the health technologies keep progressing, more complex and the not usually thought of anomalies become more recognized. Presenting to you a rare case of Herrlin-Werner-Wunderlich syndrome. A 13-year-old girl presented with dysmenorrhea with a pain scale of 10 out of 10, 5 months after her menarche. While advances in the health technologies keep progressing, more complex and the not usually thought of anomalies become more recognized. While advances in the health technologies keep progressing, more complex and the not usually thought of anomalies become more recognized. Presenting to you a rare case of Herrlin-Werner-Wunderlich syndrome. A 13-year-old girl presented with dysmenorrhea with a pain scale of 10 out of 10, 5 months after her menarche. Once her menses were over, crampy hypogastric pain with a pain scale of 6 to 7 out of 10 persisted, radiating to the back, associated with whitish non-foul discharge. No consultation was done until 5 days prior to admission due to persistence of symptoms. She's a known asthmatic with unrecalled last attack and without maintenance medications. She's a grade 8 student without sexual activity. Transabdominal ultrasound revealed uterine anomaly. Transrectal and abdominal 3D ultrasound revealed uterine didelphys, double cervix, longitudinal obstructing vaginal septum, left adnexal cyst suggestive of an endometriotic ovarian cyst, and a right adnexal mass suggestive of a benign multilocular ovarian cyst. Left kidney was absent. She was then admitted for surgery. Physical examination revealed stable vital signs. Breast and external genitalia, Tanner stage 2. The abdomen revealed a 7 by 7 centimeters, smooth, hard, movable, non-tender hypogastric mass, with the following salient features. Endometriosis, ovarian new growth, and pelvic infection were the initial considerations. Although she had no urinary or bowel symptoms, urinary and gastrointestinal conditions were also considered. In pediatric patients presenting with gynecologic problems, congenital anomalies must also be ruled out. The preoperative diagnoses were Herrlin-Werner-Wunderlich syndrome, bilateral ovarian new growth, probably benign. Ultrasound of KUB revealed absent left kidney. CA125 was elevated. The patient underwent combined laparoscopy and hysteroscopy. On laparoscopy, the uterus had 2 separate corpora. Both ovaries were cystically enlarged. The left ovary was enveloped by the omentum. It was adherent to the left pelvic sidewall and rectosigmoid column. The left ovarian mass was then punctured, draining thick, chocolate-colored fluid with smooth internal wall. Left salpingo-oophorectomy was done. On hysteroscopy, a longitudinal vaginal septum with obstructed hemivagina was noted, filled with old blood. It was punctured and excised. Histopathology report of the left ovary was consistent with endometriosis. The final diagnoses were pelvic endometriosis with left endometrioma stage 3, Herrlin-Werner-Wunderlich syndrome, longitudinal vaginal septum. Obstructed hemivagina with ipsilateral renal anomaly in combination with uterine didelphys is known as Herrlin-Werner-Wunderlich syndrome. Herrlin and Werner in 1971 described this. There is a 0.5 to 6.7% prevalence in the general population. 0.1 to 3.5% is the reported incidence in the Philippines. This Mullerian anomaly is due to the failed fusion of the paired Mullerian ducts around 12 weeks age of gestation, causing the uterine didelphys. At 20 weeks age of gestation, due to failure of the lateral fusion of the paired Mullerian ducts or failure of the resorption of the vaginal septum, presence of a longitudinal vaginal septum occurs. The early failure of the metanephric diverticulum to develop at 5 weeks age of gestation from the mesonephric duct results in a genesis of the ureteric bud, thus a genesis of the left kidney. These are the signs and symptoms. The patient presented with dysmenorrhea and pelvic pain, abdominal mass, and minimal whitish non-foul discharge. The blood buildup on the left hemivagina produced dysmenorrhea and persistent hypogastric pain. There are two types of Hurlin-Werner-Wunderlich syndrome, complete and incomplete. Classification 1 has a completely obstructed hemivagina with or without cervical aplasia, while classification 2 has a small communication between the vaginas or uteri. The patient has classification 1 because the onset of symptoms and diagnosis were 4 months after menarche. Dysmenorrhea, abdominal pain, and endometriosis were present. The progression to secondary endometriosis and adhesions was quick and easy. Diagnosis includes 3D ultrasound, MRI, 2D ultrasound, and combined use of hysteroscopy and laparoscopy, which is the gold standard. Treatment involved a multidisciplinary approach by a multidisciplinary team with a reproductive medicine specialist, general surgeon, and a nephrologist. The patient and her mother were properly informed and counseled of the entire procedure and the possible complications. The goals of the treatment were the drainage of the hematocolpos and the hysteroscopic resection of the septum, which is the standard treatment for obstructed hemivagina. Due to the obstruction, there is retrograde menstruation causing endometriosis, which is responded to by the body by forming scar tissues causing adhesions, and to which left salpingo-oophorectomy and enterolysis were done. Months after the patient's surgery, she has been doing well. Follow-up and serial monitoring has to be performed since the presence of a renal anomaly predisposes the patient to long-term complications such as hypertension. What seemingly was just a common complaint of dysmenorrhea could have been inadequately treated if not for thorough investigation of the true pathology. A high index of suspicion and the advanced imaging technology by 3D pelvic ultrasound were of paramount importance in the diagnosis and subsequent management of the patient. The reproductive prognosis is good. However, the impact on future fertility has to be determined. Forthcoming complications brought about by the effects of the anomalies and the surgical treatment they required have to be monitored throughout for a good quality of life. Thank you. As a resident physician who is under the obstetrics and gynecology residency training, to promote a healthy sense of physical identity to this 13-year-old patient of ours who has a double uterus, First off, it is important to refer the patient for counseling to a psychologist or a psychiatrist who has the best training and the proper education to address the needs of this patient, not only emotionally but also psychologically. So we had financial constraints for this patient, so we were not able to refer this patient to a counselor, but we doctors counsel the patients and we teach them using layman terms so that all their questions or all their queries will be addressed.
Okay, so thank you. So thank you for that answer. So
For kind of long-term monitoring that this patient will be having, first off, post-operatively, the patient should follow up 1 week after the operation for possible acute complications of the operation. Afterwards, a 3-month follow-up is recommended. So for recommended, and then after 6 months, monitoring of the kidney status with the serum creatinine should be done, and a 3D pelvic imaging may also be warranted. After a year and yearly thereafter, the evaluation of the kidney status should be done with serum creatinine determination. In addition, the blood pressure should be monitored daily. And if ever the patient desires to be sexually active in the future, or if she's desirous of pregnancy, she should also go to her gynecologist for a wellness checkup. Any maintenance medications. So as of the moment, we are not giving the patient any maintenance medications since post-operatively she is apparently well and she has no pelvic pain, no dysmenorrhea. However, if the pain will recur, the dysmenorrhea as well, we may give the patients medications that will suppress the estrogen levels, which is causing the pain. So we may give the patient oral contraceptive pills, we may give them GnRH, and we may also give them implants. Thank you.
Okay, so thank you, Dr. Serrano, for answering the judge's question. So once again, may I remind everyone to please vote for your favorite interesting case reports. So once again, link is displayed at the YouTube live comment section. Thank you. So let's proceed to our sixth presenter.
Hello, mic test. Ischemic stroke is one of the leading causes of death and disability worldwide, a multifactorial disease commonly affecting the elderly, but now also getting to be more common among the younger population. Stroke can cripple the economy of one family, especially if the breadwinner becomes debilitated. Most common etiology is due to atherosclerosis and cardioembolization. However, there are also uncommon causes as well, such as a carotid dissection, which escapes recognition or can be missed without high index of suspicion. I am Dr. Karen Recoleto. Again, okay. Hello, mic test. Ischemic stroke is one of the leading causes of death and disability worldwide, a multifactorial disease commonly affecting the elderly, but now also getting to be more common among the younger population. Stroke can cripple the economy of one family, especially if the breadwinner becomes debilitated. Most common etiology is due to atherosclerosis and cardioembolization. However, there are also uncommon causes as well, such as a carotid dissection, which escapes recognition or can be missed without high index of suspicion. I am Dr. Karen Recoleto, presenting to you an unusual case of a 41-year-old male with stroke. A right-handed 41-year-old male came in due to 4 days onset of right-sided weakness, numbness, and slurring of speech. This was associated with mild left lateral neck pain, frontal headache, and he had trouble finishing sentences, prompting consult. A known hypertensive, survived a stroke 5 years ago with no residual weakness. He has ptosis of the left eye, allegedly noted since birth. Family history showed the following. He is also a chronic smoker. On assessment, patient was obese, alert, and conversant with normal vital signs. Neurologic exam revealed expressive aphasia with 3/5 right-sided extremity motor weakness with Babinski. Deficits compatible with left middle cerebral artery territory and was confirmed on CT scan. Patient was managed as a case of acute left middle cerebral artery territory infarct. He was given dual antiplatelets, neuroprotectants, and antihypertensives. At the ward, blood pressure was well controlled and symptoms did not progress. Because he is relatively young, less than 45 years old, additional workups were done to determine the etiology. There was no evidence of any cardioembolic focus on 2D echo. Hypercoagulable state and connective tissue diseases were ruled out. On the 4th hospital day, carotid duplex scan was performed to complete the workup. The result was anticipated to be delayed, and at this point, patient was clinically stable. Since there are no additional treatments that cannot be carried out at home, he was discharged and was advised to maintain on the following. The patient was home for 2 days, and in that short interim, intermittent, moderately intense lateral neck pain persisted, together with the worsening of right-sided numbness. The motor weakness and aphasia remained. Carotid duplex scan result came out and showed a dissection of the left common carotid artery. This then prompted an immediate recall of the patient for readmission. At the emergency room, he was re-examined, and there was a note of new onset meiosis and medial rectus palsy of the left eye, which was not observed in the previous admission. No anhidrosis was noted. This new finding of meiosis plus a left eye ptosis, though noted since birth, led us to entertain a partial Horner syndrome. A CT angiogram was done, but this showed instead a local segment 40 to 50% stenosis of the cervical segment of the left internal carotid artery. In some circumstances, CT scan misses the diagnosis, and dissection may be viewed as stenosis when the mural hematoma obliterates the true lumen. Digital subtraction and magnetic resonance angiography would have been more diagnostic. It was, however, not available. Carotid duplex scan have shown evidence of an intimal flap, highly suggesting a proximal left common carotid artery dissection with a near total occlusion of the proximal left internal carotid artery. This finding, together with a partial Horner syndrome, plus the telltale sign of a lateral neck pain, which is not common symptom for stroke, but was prominent in this patient, a diagnosis was made. Spontaneous, chronic, common carotid artery dissection. His treatment of dual antiplatelets was shifted to anticoagulant. He was on NOAC upon discharge. During the course of his admission, there was significant improvement in the motor strength, resolution of left lateral neck pain, headache, and right-sided weakness. Within a few days of anticoagulant, his motor function fully recovered, and Broca's aphasia also resolved. Ptosis and meiosis persisted. He was able to go back to work and become productive again in life. Stroke is one of the most common disease we encounter in our daily practice. Usually, the etiology is being regarded as atherosclerotic or cardioembolic event. In a financially constrained patient, often than not, we stop our workup after CT scan has localized the parenchymal lesions. Hence, without high index of suspicion, we don't usually perform a carotid duplex scan anymore, and that would miss an important diagnosis. Carotid artery dissection comprise 2.5% of stroke's etiology, though much higher at 5 to 22% for the age group below 45 years old, more common in males. Since it is not so common, it can easily be unrecognized, even by the most experienced practitioner. A thorough workup is therefore imperative. Internal carotid artery is the most common site. In my review of literatures, I have found only one local case of carotid artery dissection, a 36-year-old female who presented with motor deficits and Broca's aphasia. Diagnosis was missed out by carotid duplex study and instead was demonstrated in a 4-vessel angiogram, which is the reverse of our case. Dissections of the common carotid artery is rare, and incidence is not known. To date, there is no reported case locally on spontaneous common carotid artery dissection. Etiologies include the following. The patient in this case presented had no history of trauma with no other disease entities identifiable. Hence, we say this is a case of a spontaneous dissection. The pathophysiology begins with formation of a mural hematoma producing local compression of the surrounding structures. The triad of ipsilateral pain in the head and neck, Horner syndrome, and the evidence of ipsilateral cerebral ischemia manifest only in 33% of patients. Conservative medical management is the treatment. Anticoagulation is preferred over antiplatelet. Endovascular and surgical repair are considered mainly for patients who have the following. Overall, prognosis is good. Recognition and timely intervention is crucial. Due to this, 95% of patients may have rapid, partial, or complete recovery. A 41-year-old man had a stroke at the prime of his life, affecting his productivity and took away his chance to enjoy life. But due to recognition of symptoms and prompt initiation of treatment, he was able to regain his function, having another chance to enjoy his life to the fullest. Ladies and gentlemen, I presented to you this case in order to raise awareness of an important cause of stroke that is commonly unrecognized even by the best. Spontaneous common carotid artery dissection in a 41-year-old male with stroke. Good morning.
Thank you so much, Dr. Recoleto. So we'll wait for the judges' question. Okay, so let's start with Dr. Melissa C's question. So if you were the physician of this case, would you stick to the old recommendation by initiating traditional anticoagulant therapy, or would you still start the patient with new, currently controversial meds, and why?
So if I were the attending physician of the patient, I would still stick first to the traditional treatment of anticoagulation. So actually, this is what was done in the patient. So for the first 5 hospital days of the readmission, he was given first a subcutaneous anticoagulant, so that was enoxaparin, so which resulted to rapid recovery of symptoms. So in just 3 days of anticoagulant subcutaneous administration, from 3/5 motor weakness, there was already improvement to 4/5. So if I am the attending physician, I would admit this patient and administer first a subcutaneous anticoagulant, and with note of improvement of symptoms, then I would probably consider shifting it to a novel oral anticoagulant upon discharge as maintenance.
So for Dr. Dova's question, what can you identify in your patient's social history that contributed to the pathology of the stroke, and how are you going to integrate that in your follow-up care with the patient?
Okay. So for this patient, he was a chronic smoker. And given that he is also a hypertensive and an obese male, smoking is actually one of the risk factors for developing a stroke. So in educating this patient, it is also important to emphasize on the cessation of smoking. I think that would be really helpful to prevent further recurrence of stroke.
Okay, so waiting for Dr. Prantilla's question. Okay, no question from Dr. Prantilla. So thank you very much, Dr. Recoleto, for your
Thank you very much.
presentation. So let's proceed with our seventh presenter.
The human face is the organic seat to beauty. It is the register of value in development, a record of experience, whose legitimate office is to perfect life. Good morning, everyone. This is a case of a 17-year-old female from Daegu City who presented with painless facial asymmetry. With a 4-year history of gradually enlarging left facial swelling, initial biopsy showed chronic inflammation and progressive swelling was noted, until it was associated with recurrent, clear, mucoid, non-purulent discharge of the left nasal area. CT scan was done, revealing an expansile, multiloculated mass at the left maxillary sinus wall involving the nasal septum and the hard palate. A repeat biopsy was done and revealed granular cell ameloblastoma. Patient was advised for surgery and was admitted. On admission, the only pertinent physical examination finding was an evident facial asymmetry. The patient's left cheek was swollen with the following margins: non-erythematous and non-tender to touch. The patient's left lip is lower than the right. No difficulty in opening and closing the mouth, as well as chewing and swallowing. Sensation is intact and the bimanual examination is unremarkable. The differential diagnosis considered are the diseases that would show multiloculated expansile mass on CT scan and presents as painless facial asymmetry. Peripheral ossifying fibroma was ruled out because the patient did not present with a red, ulcerated, and nodular lesion on the gingiva that is secondary to chronic irritation. Fibrous dysplasia was also ruled out because the patient manifested the symptoms when she was around 13 years old, no burnout pattern noted, no nodular lesions appreciated, and no skin pigmentations or presence of endocrinologic abnormalities. The last disease was ameloblastoma. It is a neoplasm that arises from the odontogenic epithelium or the tissues that give rise to the teeth. It comprises only 1% of all tumors of the jaw. It is a slow-growing tumor but is locally invasive to the surrounding structures. It mostly involves the mandibular area in around 90% of cases and affects the molar ramus area in 70% of cases. Among the three differential diagnoses, this was highly considered as the CT scan result showed local invasion and involvement of the surrounding structures extending from the hard palate and just below the orbital floor. Furthermore, repeat biopsy of the patient showed granular ameloblastoma. The patient was admitted and was scheduled for operation. A left maxillectomy with maxillary reconstruction using iliac bone graft was done. Intraoperative finding of a 3 by 3 centimeter lobulated, fixed fleshy mass adherent to the left maxilla extending from the infraorbital area up to the left gingival area. It sits on top of the hard palate and showed no invasion of the bony surfaces. The entire mass was removed with approximately 1.5 centimeter bony margin, leaving a 6 by 6 centimeter defect. Iliac bone was then harvested to be used as a graft to cover the defect. Post-operatively, the patient was generally stable and was not noted with any complications. Final histopathologic report revealed ameloblastic carcinoma. The patient was discharged with the following diagnosis. Ameloblastoma has three clinical types, with multicystic or solid type as the most common, accounting for 86% of cases and to which our patient's disease classification fell into. This presents as a lobulated solid mass with bony involvement and has 10% recurrence rate with 6 histologic subtypes. The patient's second biopsy revealed granular ameloblastoma. This is a very rare tumor that accounts only for 3.5% of all multicystic or solid type. The management of ameloblastoma varies according to clinical type, with type 1 and 2 requiring simple excision. However, the third type requires surgical excision with 1 to 2 centimeter margins to avoid recurrence. Thus, the decision to do surgery to our patient is justified. But with a sudden turn of events, the final histopathologic report was noted to be ameloblastic carcinoma. In ameloblastoma, there are 2 types of malignancy. First is the malignant or metastasizing type. It is a benign histopathologic finding of ameloblastoma that has metastasized to a different location. The lung is the most common site and may involve the cervical lymph nodes as well. The second one is ameloblastic carcinoma. It shows cytopathologic features of malignancy like increased mitotic activity, increased nuclear and cytoplasmic ratio, among others, but the tumor may or may not metastasize. Ameloblastic carcinoma has 2 types. The primary type, wherein malignancy is diagnosed in the primary tumor with classic features of ameloblastoma, but the lesion would show presence of cytologic atypia. The secondary type consists of malignant changes which originates in a previously existing ameloblastoma regardless of the presence or absence of metastasis. Ameloblastic carcinoma is a very rare lesion that the current available information are mostly case reports, amounting to only 2.23% or 12 out of 538 cases of ameloblastoma reported in a 9-year study in a local hospital in China. Of the 12 patients, only 1 patient presented with maxillary involvement. In another study that was published in 1983, there were 3,600 cases of ameloblastoma reported, and only 60 of them were diagnosed with ameloblastic carcinoma. Currently, no standard of treatment is followed in treating the disease. The third histopathologic finding of ameloblastic carcinoma in our patient can be explained by the secondary type of the disease, in which the existing granular cell type have underwent a malignant degeneration in the months that the patient was lost to follow-up. Post-operatively, the patient is advised to follow scheduled follow-ups to monitor for the presence of tumor recurrence and possibility of metastasis. In conclusion, ameloblastic carcinoma is rarely encountered in clinical practice. The present management of the disease is still on a trial and error basis. For the patient, a good compliance to follow-up checkups and imaging would be best to ascertain the efficacy and adequacy of the treatment rendered. For the people in medical field, the interesting part is always arriving at the correct diagnosis and doing what is medically appropriate for the patient. But for our patient, who experienced mockery and taunting brought about by a condition she couldn't control, daily living and interactions with other people posed a huge challenge that greatly affected the patient's psyche, morale, and confidence. This case gave us a lot of opportunity for improvement, and most importantly, this gave us the opportunity to change someone's life, to give hope, and to offer to our patient a life unburdened with disease, a life where she feels normal and not different. And lastly, we must remember, physical beauty is only a superficial aspect into one's life, but the real and authentic beauty is seen within. Thank you and good morning.
Thank you very much, Dr. Claros. So for our panel of judges, you may ask your questions live. I think the technical team was able to fix the problem.
Good morning, Dr. In your conclusion, you mentioned that this case gave you the opportunity to change a life and instill hope. So, how do you promote hope in this young patient considering how the medical condition unfolds?
I'm sorry, can you repeat the question po?
I will read the question of Dr. Sayon again. So, in your conclusion, you mentioned that this case gave you the opportunity to change a life and instill hope. How do you promote hope in this young patient considering how the medical condition unfolds?
Well, first and foremost, doctor, the patient's clinical condition right now is curable and treatable. We were able to do surgery to the patient, and with a good follow-up checkup for the patient, we can monitor if there will be tumor recurrence or possibility of metastasis. With this surgery alone, excision of the mass, the excision of the mass is already satisfactory management for the patient. However, the most important thing to follow up for the patient would be the possibility of recurrence of the tumor po, Doc.
Okay, so thank you. So for Dr. C's question, would adolescent counseling beneficial to your patient before surgery or after surgery, and why? Would adolescent counseling beneficial to your patient before surgery or after surgery, and why?
Since the patient is already experiencing bullying and also criticisms, I think it would be best that the patient should also have a preoperative counseling for the patient, so as to not further damage the patient's confidence as well as morale. So it will also be best to give a post-operative counseling to the patient, and also to assure that the patient that a medical solution was already given and that the patient can now live a new and healthy life.
Okay, so okay, so it seems that the judges weren't able to hear our presenters' answer, so I think i-repeat na lang natin. So once again, so first question from Dr. Sayon. So I hope that Dr. Sayon can hear us. In your conclusion, you mentioned that this case gave you the opportunity to change a life and instill hope. How do you promote hope in this young patient considering how the medical condition unfolds?
In order for us medical practitioners to promote hope to our patient, it is important that we give assurance to our patient that we will be doing our best to help the patient, and we will try our best to help the patient, to help alleviate the symptoms of the patient. And with that, I think it will be already satisfactory to give our patients hope.
Okay, thank you. So I think the judges were able to hear your question. So for the second question from Dr. C, would adolescent counseling beneficial to your patient before surgery or after surgery, and why?
The patient already experienced bullying and criticisms even before the start of the operation. So I think it would be best for the patient to have a pre-op counseling so as not to further the damage on the patient's confidence as well as morale. And also, it would also be better to give a post-operative counseling to the patient so as to assure the patient that we already helped the patient, and that we are trying to give the patient a new life. Thank you.
Okay, and then last question from Dr. Prantilia. How is your patient doing today? Given that not much is known about this disease, what advice did you give her and her family regarding long-term prognosis and management of her condition?
With regards to prognosis, the prognosis of ameloblastic carcinoma is actually good, with a 5-year survival rate of close to 80%, and 10-year survival rate of close to 60%. The best thing to do for the patient is to do post-operative follow-up. So the patient should strictly adhere to the post-operative follow-ups that were scheduled for the patient. It is every 3 months for the first year, every 6 months for the second year, and annually thereafter. So, because for ameloblastic carcinoma, one of the things that we are actually dreading for would be the recurrence of the tumor. So for us to easily diagnose tumor recurrence or possibility of metastasis, a good outpatient follow-up would be best for the patient.
Okay, thank you, Dr. Claros. So let's proceed to our next presenter.
When a seemingly clear-cut presentation of signs and symptoms is at hand, a direct diagnosis with empiric management become a routine. But when common conditions coexist in a patient, can these routines still apply? This is a case of patient ZE, an 18-day-old male who was apparently well until 10 hours prior to admission, had sudden onset of poor suck associated with one episode of postprandial vomiting. 5 hours later, he had another episode of vomiting, but this time was noted to be projectile and bilious in character, associated with fever, thus prompting admission. ZE was born at full term to a healthy 36-year-old G2P2 mother via repeat CS with birth weight appropriate for age. He was discharged after 48 hours, able to void and with passage of meconium. He was exclusively breastfed for 1 week, then mixed-fed thereafter. Prenatal and antenatal histories were unremarkable, and there is no known family history of any congenital anomalies. For the review of systems, there is a significant absence of passage of stool 2 days prior to admission. On physical exam, vital signs were stable and anthropometric measurements were appropriate for age. ZE showed no signs of dehydration, but with pale lips and oral mucosa. Significant PE centered on the abdomen, which was noted to be distended, measuring 34 centimeters, non-shiny, with normal active bowel sounds, tympanitic, soft, and with no palpable mass. Upon admission, an imaging of the abdomen revealed paucity of bowel gas in the pelvic space and right lower quadrant. Laboratory results showed leukopenia and thrombocytosis and a positive CRP. Urinalysis revealed bacteriuria. Hence, patient was initially managed as a case of septic ileus, and appropriate antibiotics were started. When we see a neonate who presents with abdominal distension and vomiting, bowel obstruction is highly likely, which can be classified as either functional or mechanical obstruction. Under the former, necrotizing enterocolitis is the most common life-threatening surgical emergency among newborns. Though its etiology remains incompletely understood, 3 factors have been hypothesized to promote disease. However, it was less likely for the patient since he was born at full term with unremarkable feeding history and with no history of hypoxia that could cause enteral vasoconstriction, causing damage to the intestinal lining. Intestinal ileus may be secondary to infection or as a medication side effect. However, this diagnosis cannot explain the bilious vomiting of the patient, but at this time, it cannot be totally ruled out. Under mechanical causes of obstruction, with vomiting as its most common presenting sign, malrotation is a congenital variation in the rotation and fixation of the GI tract. As seen in this case, patients may present with bilious or non-bilious vomiting, abdominal distension, and pallor, and would require further ancillary tests to establish the diagnosis. Hirschsprung disease is the most common congenital neurointestinal disease, with 90% of cases found in the neonate. It is usually limited to the rectosigmoid area, but may extend up to the ileal segment. This can present with bilious vomiting, abdominal distension, and absence of passage of stool, all of which were seen in this case. On the second day of hospitalization, signs of intestinal obstruction worsened, with an increase of abdominal girth to 36 centimeters, decreased bowel sounds, coffee ground bilious OGT output. Repeat abdominal X-ray was done, which showed significant increase in the size of the dilated bowel loops. making Hirschsprung a highly likely consideration. Rectal stimulation and glycerine insertion were done, and ZE was able to pass per anus an explosive foul-smelling gas, followed by 2 episodes of watery, non-bloody stool. Emergency exploratory laparotomy was done with intraoperative findings showing gross thickening of the colonic wall extending to the sigmoid, with displacement of the cecum and with multiple fibrous bands. Biopsy of the appendix revealed absence of ganglion cells. Loop colostomy was done and a viable ileostomy as an initial stage for surgical treatment was made. For the succeeding hospital days, there was no note of any surgical complication, hence ZE was discharged. With the proximo-distal migration of the neural crests in the lower gastrointestinal tract, absence of ganglion cells in the appendix, together with the intraoperative findings, supported the diagnosis of total colonic aganglionosis with malrotation and intestinal bands. Since 2006, there has been 6,374 reported cases of Hirschsprung disease nationwide, with only 2 cases of total colonic aganglionosis reported in Manila and only 4 cases of TCA in the whole of Mindanao, making this case the first in our institution. TCA is only 5% of all cases of Hirschsprung disease, with an incidence of 1 in 500,000 cases. In the past 14 years, 588 cases of malrotation has been recorded, 60 of which coming from Mindanao. Although Hirschsprung disease and malrotation are fairly common pediatric cases, their concurrence is rare. While malrotation has been studied to be associated with multiple syndromes and anomalies, none of which is Hirschsprung disease, making this case probably the first recorded case of their concurrence. One of the challenges in managing TCA is the extent of surgical treatment to be done. While the goal is to remove the long aganglionic segment, this poses a dilemma on whether a gradual removal or a one-step surgical procedure should be done. Although all procedures are reportedly successful, none has been proven to be superior. Under underdeveloped and developing countries, the prognosis of TCA is very poor. Enterostomy alone carries a mortality rate of more than 60%, and most deaths occur during the interval between 2 procedures, due to the following factors. ZE, now 3 months old, has defied these complications, attributed to good compliance and family support. Hirschsprung disease and malrotation are fairly common pediatric cases with well-studied treatment. However, in this case, a rare extent of Hirschsprung disease, further complicated by malrotation, contributed to ZE's presentation. One would imagine that these findings would confound the team as to the best action to address both conditions. But luckily, the management of both was quickly thought of and carried out in a way like hitting 2 birds with 1 stone. Thank you.
Thank you very much, Dr. Casilag, for your presentation. So for our panel of judges, is it okay if you're going to ask your questions live?
Good noon, doctor. So my question, as a pediatrician, how did you prepare the parents to meet the specific needs of ZE in consideration of his medical history?
Sorry, Doc.
Sige, I will be the one to repeat Dr. Sion's question. So, as a pediatrician, how did you prepare the parents to meet the specific needs of ZE in consideration of his medical history?
It was important that a multidisciplinary team was made. Together with the Department of Surgery, the family had a meeting with regards to the possible prognosis and complications of the patient. Hence, prior the operation, all possibilities were discussed with the parents, and the prognosis of each outcome was discussed and further explained to both parents.
Okay, so for Dr. Prantilla, is it okay if you're going to read your questions live po?
Hi, I'll try. Okay ang audio? I'd like to know if a colectomy was done on your patient, and if so, what is your nutritional plan for your patient post-op?
For this patient, a colectomy is still scheduled po, Doc. An ileostomy was still done since during operation, the diagnosis of total colonic aganglionosis was still not established. Also, it helped prepare the parents for both the financial and psychological impact of the diagnosis to the family.
And then for Dr. Melissa C., is it okay if you're going to read your question live?
Hi, good afternoon. Regarding your patient, is your patient at risk for malnutrition? If so, how would you manage and prevent nutrition deficiencies of this patient?
Good afternoon po, Doc. As with any other post-operative complication, malnutrition is highly likely a complication for this patient, and it is important to facilitate and meticulously follow up this patient and to refer the patient to appropriate services such as nutrition, gastro, and follow-up should be emphasized to prevent malnutrition and other complications of the operation.
Okay, thank you so much, Dr. Casilag. So let's proceed to our second to the last presenter.
Mic test. You think life may take more than it gives, but not today. Today, it is giving our patient a chance to live. RH is a 4-month-old infant brought to the emergency room for pallor. 11 days prior to admission, she had non-productive cough and non-bloody diarrhea. CBC showed anemia. She was given amoxicillin and iron with poor compliance. In interim, with resolution of diarrhea but cough persisted. A day prior, there was melena, pallor and weakness with no fever, irritability, or hematemesis. CBC showed further decrease of hemoglobin with leukocytosis and thrombocytopenia. She was then admitted. She was exclusively breastfed since birth. Her developmental milestones were at par with age, and her immunization status was up to date. Family history was unremarkable. RH was awake but weak looking, with generalized pallor. Anthropometric measurements and vital signs were normal. There was no signs of dehydration and heard crackles on both lungs upon auscultation. Upon admission, with persistence of cough and diarrhea, chest x-ray was done, which showed infiltrates in both lung fields. And stool exam and culture revealed unremarkable results. Hence, antibiotic was started. Due to severe anemia and thrombocytopenia, blood transfusion was done. There was no improvement of thrombocytopenia, prompting further investigation. There are 2 possible etiologies causing thrombocytopenia: decreased platelet production and increased platelet destruction. ITP occur in any previously healthy patient with sudden onset of mucocutaneous bleeding with no history of systemic symptoms. Normal CBC and reticulocyte count are laboratory findings consistent with this condition, all of which were not seen in this case. Vitamin B9 and B12 are 2 important vitamins for normal hematopoiesis. Vitamin B12 deficiency may be seen in breastfed infants of both B12 deficient mothers. However, it is not likely, as both the patient and the mother does not exhibit the signs of this deficiency. The red cell indices of these vitamin deficiencies are megaloblastic, further making this diagnosis unlikely. Persistence of thrombocytopenia warrants investigation, particularly when symptoms like gastrointestinal bleeding develop. Certain infections such as EBV, flavivirus, and other severe type of infection can cause thrombocytopenia. However, viral manifestations were absent and the coagulation abnormalities expected in DIC were not present. making this cause unlikely. Peripheral blood smear revealed the following: normocytic hyperchromic red cells with numerous schistocytes, ring cells, helmet cells, and macrocytes, suggestive of microangiopathic hemolytic anemia. Although manifestations of leukemia such as pallor, anemia, thrombocytopenia, and leukocytosis were seen in this case, the reticulocyte count was elevated, suggestive of bone marrow response to either hemolysis or blood loss, and the PBS findings showed more of moderate anisopoikilocytosis than the presence of blast cells or immature WBC. This made the diagnosis of leukemia unlikely. On the third hospital day, RH was oliguric, warranting investigation of kidney function. Serum creatinine and BUN levels were markedly elevated, indicating renal insufficiency. Microangiopathic hemolytic anemia, thrombocytopenia, and acute kidney injury. These are the three pertinent findings of this case. This triad is consistent with two disease entities: hemolytic uremic syndrome and thrombotic thrombocytopenic purpura. TTP is characterized by small vessel platelet-rich thrombi that causes these pentad: microangiopathic hemolytic anemia, thrombocytopenia, fever, acute renal failure, and severe neurologic findings. It is not likely, as the pentad is not fulfilled in the absence of fever and severe neurologic findings, leaving HUS as the primary diagnosis. Peritoneal dialysis was initiated, and monitoring of the serum creatinine, BUN, and electrolytes showed gradual improvement until normal. Good urinary output was established, and the repeat PBS showed lesser number of schistocytes. RH was discharged with resolution of infection, anemia, thrombocytopenia, and azotemia. For over 14 years in the Philippines, there is a total of 8 HUS cases for ages less than 1 year old, of which 1 is from Davao City. This is the first case of HUS admitted in our institution. HUS can be classified according to their etiology: genetic, drug-induced, those associated with systemic diseases, and those secondary to infectious causes. Infectious cause of HUS can be due to E. coli or Streptococcus pneumonia. Typical HUS is caused by Shiga toxin-producing E. coli, which accounts for 90% of cases of childhood HUS. Its natural reservoir is the gastrointestinal tract of the cattle and other ruminant animals. RH is purely breastfed, making this source less likely. Spread by person-to-person contact is the possible cause of her HUS. A typical HUS includes triad with no history of diarrhea. Infectious cause is due to Streptococcus pneumonia, which has been reported in 5 to 15% of childhood HUS cases. This microorganism produces neuraminidase, which cleaves endothelial cells, RBC, and platelets, exposing TF antigen, which is recognized by endogenous IgM, creating a complex triggering microvascular angiopathy. Although RH received 3 doses of PCV, this study showed that the pneumococcal infection remains a major cause of HUS despite improved vaccine coverage. Although RH had leukocytosis and pneumonia, suggestive of bacterial infection, focal lobar lung lesion typical for streptococcal infection was not seen. Toxins cause platelet aggregation, causing consumptive thrombocytopenia. Red blood cells passing through the damaged and thrombotic microvasculature causes mechanical damage, resulting in microangiopathic hemolytic anemia. The dilemma of antibiotic use in these children is still of debate. One study concluded that antibiotics in children with E. coli infection increases the risk of HUS. Also, according to WHO, antibiotics are not recommended for suspected staph infections. Fortunately, the use of antibiotics did not worsen our patient's condition. Whether enteritis or renal insufficiency predominates, supportive care and early dialysis if patient becomes oliguric or hyperkalemic is necessary. Platelets should not be administered as they are consumed by the active coagulation and can worsen the clinical course. Mortality rate is less than 5%. Most recover renal function completely, but of surviving patients, up to 30% have chronic renal insufficiency. This case is a reminder to all healthcare providers that the success of patients' challenging story will always depend on prompt recognition and timely management. Early recognition can save lives, and it saved the precious life of RH. Thank you.
Thank you so much, Dr. Azuro. So for our judges, you may ask your questions live.
Good afternoon. Hello. Okay. For for your patient, you said that lifelong follow-up is needed. So how would you explain it to the parents, and what are those what to watch out for, and any home instructions?
Okay. So once again, the question from Dr. Prantilla. Looking back, how would you have improved the man? Sorry. I'm so sorry. Dr. Sayon. Okay. Okay. Dr. Sayon, can you please? Okay. Okay. So sorry. So it was Dr. Melissa C who asked the question first. So how would you explain to the parents of lifelong follow-up what to watch out for and any home instructions?
So with regards to the treatment plan, part of the treatment plan is making the patient's parents understand the disease entity. So this involves explaining to them the importance of the in-hospital and out-hospital management and monitoring. So we should emphasize to them that the treatment should not be isolated, it should not end within the walls of the hospital. So with regards to the follow-up checkup, I have encountered journals saying that patients with HUS had 10-year follow-up checkup. However, up to this date, there is no consensus with regards to the frequency of the follow-up or the testing or the laboratory tests required.
Okay, thank you very much. So Dr. Prantilla, is it okay if you're going to read your question?
Hi. Looking back, how could you have improved the management of your patient? Would you change anything?
Good. Thank you for that question, Doc. So with regards to the management of the patient, since the patient was then outright diagnosed with HUS, so recalling from my discussion a while ago, WHO recommended, with emphasis of recommendation, that antibiotics should not be used in patients who have solely HUS diagnosis. If I were the attending physician, I will not change the treatment management, for we know that when the patient was admitted, the patient had concomitant respiratory infection. So we cannot disregard the respiratory infection. We cannot just regard the respiratory infection.
Thank you, Dr. Azuro. So for Dr. Sayon, no questions from her. So thank you so much. And let's proceed to our last presenter.
Mic test. The pea-sized black ball smelled pungently sweet, like molasses. He swallowed the little balls 3 times a day. Just like magic, all his aches gone. Good afternoon. This is cow's head pills, known as Chinese black balls. Unfortunately, what was considered safe was containing steroids. This is the magical turn to tragic story of JMO, 31-year-old male, diabetic for 10 years, smoker for 10-pack years, who came into the emergency room with rotatory dizziness. Morning prior to admission, he felt nauseous with blurring of vision. The dizziness was associated with occipital headache. At his office, he experienced difficulty in expressing self, as well as understanding his colleagues. Persistence and above symptoms prompted admission. At the ER, he was examined awake, coherent, not in respiratory distress. Vital signs revealed an increased blood pressure. Upon physical exam, moon-like fasces, central obesity, buffalo hump, and multiple whitish striae were noted on the abdomen and arms. Neurologic physical findings, cranial nerve examination, motor strength, and reflexes were unremarkable except for the expressive aphasia. Dix-Hallpike maneuver was done, no nystagmus noted. Hence, the patient was admitted with an impression of. The following diagnostics were ordered. Medications are the following. Complete blood count revealed leukocytosis with neutrophilic predominance. HbA1c and FBS were both elevated. Dyslipidemia, hyponatremia, and hypokalemia were noted. Initial 12-lead ECG revealed sinus rhythm. Chest X-ray findings were normal. Serum creatinine was elevated. A referral to nephrology was done for clearance prior to cranial CT. Referral to neurology service was also done. Cranial CT scan with contrast revealed. Dual antiplatelet therapy was started. On the first hospital day, there are still complaints of dizziness, knee pain, expressive aphasia. CBG levels were still elevated. Additional laboratory results are the following. At this point, this was the consideration. Oral prednisone was started, and a request for serum cortisol was ordered to check for adrenal insufficiency. On the second hospital day, there was no dizziness and headache. Endocrinology service started tapering of oral prednisone. Serum cortisol and thyroid panel were normal. A referral to speech therapist and dietitian was made. On the subsequent days, he was observed to have visual hallucinations. He was discharged the following day with a final diagnosis of. The following salient features on this case are presented with a patient complaining of dizziness. The following diagnoses are likely. Migraine headache was entertained due to the following. This condition can be ruled out based on the criteria specified by the International Classification of Headache Disorders. Intracranial masses was also considered due to the following. This is ruled out due to the absence of signs of increased intracranial pressure. Hypothyroidism was considered in this case due to the following. However, it is less likely due to the normal thyroid panel. Hyponatremic encephalopathy was also considered due to the following. This is ruled out due to the absence of anorexia, loss of appetite, muscle cramps, and weakness. Meniere's disease and BPPV were also considered, however ruled out due to the absence of tinnitus, hearing loss, and nystagmus in Dix-Hallpike testing. Lastly, cerebrovascular accident is more likely due to the presenting symptoms of the patient, which include. This cannot be totally ruled out. But we don't stop here. When the features such as moon fascie, buffalo neck, expressive aphasia, visual hallucinations, history of myopathy, gastrocnemius atrophy, and the intake of Gauss head pills, exogenous Cushing syndrome was highly considered. The use of complementary and alternative medicine is nothing new in the Philippines. Its popularity is associated to the misconception that it is natural, cheap, safer to use, and thought to be more effective. Unfortunately, this is not in the case of Gauss head pills. Its label is not what it seems. Studies have shown they were adulterated with steroids. Steroids in the right amount is body's best friend. In the wrong amounts, the body's worst enemy. Cushing syndrome is defined as a state of glucocorticoid excess. Its incidence is not known. Interestingly, Cushing syndrome induced by ingestion of Gauss head pills was not reported in the Philippines and locally. Hopkins et al. Stated that exogenous Cushing syndrome presents as the same signs and symptoms with spontaneous Cushing syndrome. Weight gain, which is the most common clinical finding, presenting as central obesity with redistribution of fat to the trunks, buffalo hump, and the classic moon fascie, which are case manifested. The patient had also renal failure, attributed to his long-standing diabetes mellitus. However, several cases report incidents of herbal-induced nephrotoxicity. Acute interstitial nephritis was also associated with cow's head pill intake. Persistent expressive aphasia and visual hallucinations were also noted during the hospital stay. This has been reported. The diagnosis requires first and foremost clinical suspicion, exclusion of endogenous CS, and measurement of the steroid in question, in this case, cow's head pills containing betamethasone. According to the Endocrine Society Clinical Practice Guidelines, treatment of Cushing syndromes include normalization of comorbidities, adjunctive treatments. The patient was started on oral prednisone with subsequent tapering. A diagnostic criteria created by Loyon Hostel et al. Was created to determine if there's a risk for Cushing syndrome. Given the presence of buffalo hump and muscle atrophy, the patient's score is 5. If the night salivary cortisol has been done, the diagnosis of Cushing syndrome is likely. Sometimes, a simple CVA is not just a complication of diabetes mellitus. It could be something else. Like in this case, the exacerbation of the diabetes mellitus led to the stroke of the patient, brought about by prolonged intake of cow's head pills. Indeed, there is more than what meets the eye. Not all that appears shiny, black, and beautiful equates magical. Sometimes, as in this case, it can hurt and break us. The little magic balls became a big wrecking ball. Thank you.
Thank you, Dr. Bernaldez, for your presentation. So once again, to our judges, do you have any questions?
So the question is, as a family physician following through a young patient with compliance issues, aside from the financial constraints, what is or are the patient's context of non-adherence, no, that made him vulnerable to try cow's head pills?
Thank you for that question. So before I answer that question, I would like to highlight that in family medicine, it is very much important that relationship is built with our patient, with our index patient, as well as their families. So in the question stated, what are the other things that made the patient go into taking the cow's head pills and not take his maintenance medication? So first will be it's his ignorance about the medications that he needs to take. So this patient has been diabetic, doc, for almost 10 years, but he did not comply with his medication. So he believed that this medication given by the doctors are the one causing renal failure. So patient education is very much highly needed for this patient, so as there will be no more untoward incident such as this thing that happened to him.
Thank you.
For the other judges, do you have any questions? So none for Dr. Pradilla. And how about for Dr. Melissa C? Do you have any question? Okay, so thank you so much, Dr. Bernaldez. So thank you very much to all the contestants for presenting your case reports. But just so you know, you only have 1 more minute before the poll for the Voters' Choice Award closes. So to our audience, get your computers, tablets, phones, click the link and vote for your favorite interesting case reports. So once again, for our audience who are watching us via YouTube Live, continue to vote for your interesting case report so that we can award one of our presenters with the Voters' Choice Award. And we are down to 10, 9, 8, 7, 6, 5, 4, 3, 2, and 1. So the voting is now officially closed. So the winner for the Voters' Choice Award will be revealed after the intermission number. So, isn't it amazing and isn't it exciting? Well, I gotta say, while listening to your presentations, I was mind blown of how much effort these contestants have done with the help of their mentors in order to arrive at the diagnosis and management. It was all informative and indeed interesting. So for all of the contestants, kudos to all of you and give yourselves a round of applause. So to the rest of the audience who are watching us live via YouTube, hopefully you all learned a lot, and I have a feeling that the consultants and residents from different departments are screaming and jumping for joy as their colleagues are presenting and defending their case presentations. So while the judges are calculating the scores, and also to calm down the nerves of our contestants after successfully showcasing their interesting case reports, we will have a virtual intermission number by our postgraduate interns. So let's give them a round of applause.
Labis nang naiinip, niyayamot sa bawat sandali. Kapag naalala ka, wala naman akong magawa. Umuwi ka na, baby. Di na ako sanay na wala ka. Mahirap ang mag-isa. At sa gabi hinahanap-hanap kita. Hanggang kailan ako maghihintay na makasama kang muli sa buhay kong puno ng paghirap. Tanging ikaw lang ang pumapawi sa mga luha at naglalagay ng ngiti sa mga labi. Di mapigilang mag-isip, mabaka sa tagal, mahulog ang loob mo sa iba. Nagkakabalisa, knocks on wood, wag naman sana. Umuwi ka na, baby. Di na ako sanay na wala ka. Mahirap ang mag-isa. At sa gabi hinahanap-hanap kita. Hanggang kailan ako
when I'm lonely in the dark. I know you are with me, yeah. Don't you see that I need you so much? Don't you see that I love you so much? Oh na 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 na, oh na 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 na, darling, I need your love.
Talented talaga ang ating mga interns. So, I think it's safe to say that the judges have finished computing the scores. So are all of you excited to know who are the winners of the 13th Interdepartmental Interesting Case Presentation? But I would like to keep the suspense rolling. So, before announcing the winners of the Interdepartmental Interesting Case Presentation, so I would like to ask our panel of judges if they can turn on their cameras as I read to them the citation for your certificates of appreciation. Okay. So I would like to read the citation. So the Broken Chair Integrated Health Ministries Incorporated Graduate Medical Education Training Office presents the Certificate of Appreciation to our panel of judges, Dr. Florence Prantilla, Dr. Melissa C., and Dr. Dova Sayon Gonzalez for being one of the distinguished judges of the 13th Interdepartmental Interesting Case Presentation Contest. Given this 2020, Emma Noreen Hall, Bimi, Davao City, Philippines, signed by Dr. Laricel Pagican, MD, Dr. Mina Angelica Bernardino, Dr. Michael Hamiana, and Bishop Jaime R. Moriles.
Thank you.
Thank you.
So, the time has finally come to announce the winners of the 13th Interdepartmental Interesting Case Presentation. So once again, are you all excited to know the winners? Okay. So of course, all of us here are very excited. But firstly, I would like to announce first the winners of the Voters' Choice Award. So the Gemetto team has tallied the number of votes. So let's show the pie chart. Okay. Maklaro ba? Pwede ba siya ma-enlarge, sir, para makita sa ating mga audience, especially those who are watching us via YouTube Live? Okay. So for the Voters' Choice Award, with a score of 24%, the Voters' Choice Award goes to Dr. Adeline Bea Bernaldez. Sakto ba? At 24%, Dr. Adeline Bea Bernaldez. So congratulations to our, I'm so sorry. Thank you so much. And congratulations to Dr. Bernaldez. Okay. So now for the most exciting part of the program, the winners of the 13th Interdepartmental Interesting Case Contest. So since the judges are not here to award our winners, so I would like to call on Dr. Larissa Bagican to announce the winners.
Good afternoon. So finally, here are the winners. Let me start off by giving to you the best presenter. The judges chose the best presenter to be Dr. Aliana Catresha Casilag of Pediatrics Department. A rare case of Hirschsprung disease and intestinal malrotation in an 18-day neonate. The third place. The third place had an average score of 88%. The award goes to Dr. Alan O. Quintanar III from the Obstetrics and Gynecology Department, a 40-year-old mother with sad fetus syndrome, ethical and management dilemma. The second place. The second place had an average score of 88.7%. And it is awarded to Dr. Darwin P. Claros of Surgery, Ameloblastoma carcinoma, a rare ameloblastoma malignancy in a 17-year-old female. And now, the first place. The first place garnered an average score of 89.7%. And the first place for the 13th Interdepartmental Interesting Case Report Contest goes to Dr. Adeline Bea A. Bernaldez of Family Medicine, a case of a 31-year-old with Cushing syndrome induced by cow's head pills, a Chinese herbal medicine. Congratulations to the finalists. You are all winners. And congratulations to our placers.
Okay. Thank you very much, Dr. Bakikan. So congratulations to all the contestants and a big kudos to the winners of the 13th Interdepartmental Interesting Case Presentation. You all deserve it, and once again, let's give them a round of applause. So before we end today's program, I would like to call on the Director of the Graduate Medical Education Training Officer, Dr. Larcel Pagican, for the closing remarks. So, pre-recorded.
Good morning. This has been a fruitful and enlightening day. I hope everybody learned something from all the cases presented. I would like to thank all the residency training departments for their full support in training activities such as this. Congratulations to all the presenters and most especially to all the winners. Let us continue our quest to learn from and care for our patients. Have a good day and keep safe, everyone.
So thank you very much, Dr. Pagican. So this marks the end of the 13th Interdepartmental Interesting Case Presentation. So kudos once again to all of the contestants and a big congratulations to our winners. So once again, this is Dr. Lowell Batoon. Good afternoon to everyone and stay safe. Thank you.
When I'm lonely in the dark, you.